Hi, class. Today we're going to be discussing psychopharmacology. And psychopharmacology is the study of how drugs affect behavior. If a drug changes your perception or the way that you feel or think, the drug exerts effects on your brain and nervous system. We call drugs that change the way you think or feel psychoactive or psychotropic drugs. And almost everyone has used a psychoactive drug at some point. Yes, caffeine and alcohol count. Understanding some basics about psychopharmacology can help us to better understand a wide range of things that interest psychologists and others. For example, psychopharmacological treatment of certain neurodegenerative diseases, such as Parkinson's disease, tells us something about the disease itself. The psychopharmacological treatments used to treat psychiatric conditions such as schizophrenia or depression have undergone amazing development since the 1950s. And the drugs used to treat these disorders tell us something about what's happening in the brains of individuals with these conditions. Finally, understanding something about the actions of drugs of abuse and their roles and routes of administration can help us to understand why some psychoactive drugs are addictive. In this lecture, we will be providing an overview of some of these topics, and we will discuss some current controversial areas of psychopharmacology. Our lecture will conclude with some examples of how drugs like alcohol, opiates, cannabis, and caffeine work at the level of neurotransmitters and synapses. Let's get started. Now, first off, let's get a working definition. Psychopharmacology is the scientific study of how drugs affect the brain and behavior, and it's a relatively new science. However, people have been taking drugs to change how they feel and think since early on in human history, such as consuming fermented fruit, early forms of beer, coca leaves as stimulants, and mind altering mushrooms in rituals. The term psychopharmacology tells us that this field bridges brain, behavior, and pharmacology, encompassing a broad range, that is, of topics. Now, virtually any drug that changes the way you feel does so by altering how neurons communicate with each other. Neurons communicate with each other by releasing a chemical known as a neurotransmitter across a tiny space between two neurons, known as the synapse. We've already discussed this quite a bit. When the neurotransmitter crosses the synapse, it binds to postsynaptic receptors on the receiving end of the neuron. And the message may then be transmitted onward. Neurotransmission is far more complicated than this. And we've reviewed a number of different elements of neurotransmission in previous lectures. And it's useful to give that some thought as we discuss the content for this lecture. But the first step is understanding that virtually all psychoactive drugs modulate how neurons communicate with each other. And several neurotransmitters play crucial roles in psychopharmacological treatments and drugs of abuse. And there are some examples in this slide right here. The neurons that release these neurotransmitters, for the most part, are localized within specific circuits of the brain that mediate these behaviors. Psychoactive drugs can either increase activity at the synapse, and these are called agonists, or reduce activity at the synapse, which are known as antagonists. And I may have mentioned this a bit before, so this might be a little bit of review. But different drugs do this by various mechanisms. And examples of agonists and antagonists are also presented in the next table on the next slide. But each example includes the drug's trade names from the drug company and its generic name in parentheses. So this table provides examples of drugs and their primary mechanism of action. But it's important to realize that drugs also affect other neurotransmitters. This contributes to a drug's side effects. So current drugs lack precise targeting to specific brain regions or individual neurotransmitter systems. In many cases, individuals are sometimes prescribed one psychotropic drug, but then may also have to take additional drugs to reduce the side effects caused by the initial drug. So some side effects can be so severe that individuals stop taking their medications altogether. And in fact, when we're talking about medications for severe mental illness, sometimes this is a big challenge with, the fidelity to the drug regimen, and to sticking with the use of that drug as prescribed. Now, pharmacokinetics refers to how the body handles a drug that we take. And as mentioned earlier, psychoactive drugs exert their effects on behavior by altering neuronal communication in the brain. And the majority of drugs reach the brain by traveling in the blood. The acronym ADME is often used in pharmacology and stands for absorption, so how the drug gets into the blood, distribution, how the drug gets to the organ of interest, and in this lecture, that's the brain, and metabolism, how the drug is broken down so it no longer exerts its psychoactive effects. And finally, excretion, how the drug leaves the body. Let's examine these processes for psychoactive drugs. Now, drugs can be administered through various routes, each affecting the speed at which they reach the brain. The most common route of administration is oral administration, which is relatively slow and often the most variable route. Drugs enter the stomach and then get absorbed by the blood supply and capillaries that line the small intestine. The absorption rate can be affected by many factors, including quantity and the type of food in the stomach, so fats versus proteins. And this is why the medicine labels for some drugs, like antibiotics, may specifically state foods that you should or should not consume within an hour of taking the drugs, because they can affect the absorption rate. Now, two of the most rapid routes of administration include inhalation, so smoking or gaseous anesthesia, and intravenous, which is where the drug is injected directly into the vein and hence into the bloodstream. Now, both of these routes of administration can get the drug to the brain in less than 10 seconds. IV administration also has the distinction of being the most dangerous, because if an adverse reaction occurs, there's little time to administer an antidote, as is the case of IV heroin overdose. Now, why might how quickly a drug gets into the brain be important? Well, if a drug activates the reward circuits and in the brain and it reaches the brain very quickly, the drug has a high risk for abuse and addiction. Psychostimulants like amphetamine or cocaine are examples of drugs that have a high risk for abuse because they are agonists at dopamine, or DA, as they're referred to, neurons involved in reward, and because these drugs exist in forms that can either be smoked or injected intravenously. Now, some argue that cigarette smoking is one of the most difficult addictions to overcome, and this might partially stem from the rapid nicotine delivery to the brain, indirectly activating dopaminergic neurons. But the full story is much more complicated. For drugs that reach the brain very quickly, not only is the drug very addictive, but so are the cues associated with the drug. For a crack cocaine user, this could be the pipe that they smoke the drug with. For a cigarette smoker, however, the cue could be something as normal as finishing dinner or waking up in the morning, if that's when the smoker typically has a cigarette. Both the crack user and the cigarette smoker, for both of these people, the cues associated with the drug may cause a craving and lead to relapse. This is one of the reasons that individuals who enroll in drug treatment programs, especially out-of-town programs, are at significant risk of relapse if they later find themselves in proximity to old haunts, friends, fellow drug users, etc. But this is much more difficult for the cigarette smoker. Now, how can someone avoid common smoking cues like eating or avoid waking up in the morning? Well, you can't. And these examples can help you to understand how important the route of administration can be for psychoactive drugs. Now, Metabolism involves the breakdown of the psychoactive drug, and this occurs primarily in the liver. The liver produces enzymes, which are proteins that speed up a chemical reaction. And these enzymes help catalyze a chemical reaction that breaks down the psychoactive drugs. So enzymes exist in families, and I'm not talking about your families of origin. I'm talking about types of enzymes. And many psychoactive drugs are broken down by the same family of enzymes, the cytochrome P450 superfamily. There is not a unique enzyme for each drug. Rather, certain enzymes can break down a wide variety of drugs. Tolerance to the effects of drugs, of many drugs, I should say, can occur with repeated exposure. That is, the drug produces less effect over time. So more of the drug is needed to get the same effect. This is partially true for sedative drugs like alcohol or opiate-based painkillers. Now, metabolic tolerance is one kind of tolerance, and it takes place in the liver. Some drugs like alcohol cause enzyme induction, an increase in the enzymes produced by the liver. For example, chronic drinking results in alcohol being broken down more quickly. So an alcoholic needs to drink more to get the same effect. Of course, until so much alcohol is consumed that it damages the liver, and alcohol can cause fatty liver or cirrhosis, as well as more advanced cognitive degeneration through what's called Korsakoff's syndrome. Now, there's also certain types of food that can be in the stomach that can alter the rate of drug absorption, as I mentioned a few minutes ago. And other foods can alter the rate of drug metabolism. The most well-known is grapefruit juice, believe it or not. Grapefruit juice suppresses cytochrome P450 enzymes in the liver. And these liver enzymes normally break down a large variety of drugs, including some psychotropic drugs. If the enzymes are suppressed, drug levels can build up to potentially toxic levels. Now, this is really important. This is one of the main reasons why a lot of the time, if you're on any kind of medication, your doctor may say, avoid grapefruit juice, avoid grapefruits, things in the grapefruit family. In this case, the effects can persist long after consuming grapefruit juice. As of 2013, at least 85 drugs have been shown to interact adversely with grapefruit juice. Some psychotropic drugs that likely interact with grapefruit juice include carbamazepine, which is Tegretol, prescribed for bipolar disorder, diazepam, or Valium, used to treat anxiety, alcohol withdrawal, and muscle spasms, and fluvoxamine, or Luvox, used to treat obsessive compulsive disorder and depression. And so, you can see why it's important to be mindful of what the contraindications are with the drugs that you may be prescribed or maybe even recreationally taking, lest you might cause some inadvertent damage. Now, mental illnesses contribute to more disability in Western countries than all other illnesses, including cancer and heart disease. And globally, depression and anxiety disorders are among the highest causes of health burden. And the mental health system in most countries is under-resourced. The numbers of people affected by mental health issues are astonishing, quite frankly. I mean, the estimates are that 25% of all adults experience a mental health issue at any given year. And this affects not only the individual, but also their friends and family and people that they work with, et cetera. 1 in 17 adults experiences a serious mental illness. Now, newer antidepressants are probably the most frequently prescribed drugs for treating mental health issues, although there is no magic bullet for treating depression and other conditions. Psychopharmacology, with psychological therapy or psychotherapy, as it's referred to, may be the most beneficial treatment approach for many psychiatric conditions, but many questions remain unanswered. For example, why does one antidepressant help one individual and yet has no effect on another? Antidepressants can take 4 to 6 weeks to start improving depressive symptoms, and we don't fully understand why. I mean, the theory is that it needs to build up in the system before it actually starts to show an effect. But many individuals do not respond to the first prescribed antidepressant. May need to try various medications before finding an effective treatment, even if those different antidepressant medications are all in the same category or family of drugs, like selective serotonin reuptake inhibitors. Now, some individuals show no improvement with any antidepressants, whether they be selective serotonin reuptake inhibitors or tricyclics or MAOIs. As our understanding of individual differences improve, we can more quickly and effectively assist those in distress. Now, recent interest is focused on personalized treatment approaches. One area of focus is how genetic variations in cytochrome P450 enzymes affect drug metabolism rates. Now, the general population falls into the following 4 categories. 1, ultra extensive metabolizers who break down drugs more slowly than the 2 groups. Let me rewind there. Ultra extensive metabolizers break down drugs like antidepressants very, very quickly. So scratch that last one. Break it down very quickly. Ultra extensive metabolizers are also able to break down drugs fairly quickly. Intermediate metabolizers break down drugs more slowly than the 2 previously mentioned groups. And finally, poor metabolizers break down drugs much more slowly than other groups. So just for clarity, let's go over that again. Ultra extensive metabolizers break down certain drugs like some antidepressants very, very quickly. Then we also have extensive metabolizers, and they're able to also break down drugs fairly quickly. Then we have intermediate metabolizers who break down drugs more slowly than the 2 previously mentioned groups. And finally, we have poor metabolizers who break down drugs much more slowly than other groups. Now, consider someone receiving a prescription for antidepressants. What would be the consequences if they were an ultra extensive metabolizer or a poor metabolizer? The ultra extensive metabolizer would be told it would probably take 4 to 6 weeks for the antidepressants to begin working. And this is true, but they metabolize the medication so quickly that it will never be effective for them. In contrast, the poor metabolizer is given the same dose of that antidepressant, and it may build up to such high levels in their blood because they're not breaking down the drug that they'll have a wide range of side effects, also not a positive outcome. So what if instead, prior to prescribing an antidepressant, the doctor could take a blood sample and determine which type of metabolizer a patient actually was? They could make an informed decision about the best dose to prescribe. Well, new genetic tests are available to individualize treatment. A blood sample can determine, or at least for some drugs, determine which category an individual fits into, but we need data to determine if this actually is effective for treating depression or other mental illnesses. Now, while current costly and often not covered by insurance, these genetic testing, or these types of genetic testing, I should say, may be crucial in psychopharmacology's future. So this research, along with studies on cell membranes, neuronal DNA, and receptor site alterations, aims to explain the delayed onset of antidepressant effects. Now, a recent Centers for Disease Control, or CDC, report suggested that as many as 1 in 5 children between the ages of 5 and 17 may have some type of mental health disorder, whether this is ADHD, autism, anxiety, depression, etc. The incidence of bipolar disorder in children and adolescents has also increased about 40 times recently. And it's now estimated that 1 in 36 children have been diagnosed with an autism spectrum disorder as well. So, why has there been such an increase in these numbers? Well, this important question has no single answer. Some believe that greater public awareness has increased teacher and parent referrals. Some attribute the rise to changes in diagnostic criteria. And others suggest that environmental factors, prenatally or postnatally, have contributed to this upsurge. And this has been a hot topic, especially recently, with some claims that even Tylenol can used in utero can be or used when a mother is pregnant with a child in utero can be a risk factor for autism. And I'm not going to get into the weeds with that particular case, only to say that for those of you who have taken my research methods class, you'll remember this adage that if you didn't, you probably heard from your other research methods professor if you've taken research methods yet, or statistics professor if you've taken statistics yet, which is correlation is not causation, meaning that two things that co-occur do not mean that one causes the other, right? So one of the things we know is that when a mother has a high fever, that can put stress on the baby. It makes sense. The baby is in the body. The temperature is heating up in the body. This is potentially problematic. And infections that a mother might be fighting that are causing the fever can potentially be a risk factor to a child in utero. So why would somebody take Tylenol? Well, usually the two reasons are pain or fever. So oftentimes when you see an association that's not necessarily causal, there's a third variable that's actually responsible there. So we can't say for certain, but I'm just going to point you in that direction on that. We don't know, but the data isn't there to say that Tylenol causes autism. However, the data is there to say that there's a relationship that is non-causal, at least as far as we know, based on what are called meta-analyses, large studies of studies. But there are issues with those studies. They're often retrospective in nature. So people are asked to recall whether they took Tylenol, for example. And that's not always the best or most reliable way of making a determination. So as always with these things, talk to your doctor first and foremost. Your doctor's not getting a kickback from the Tylenol manufacturers. Your doctor is going to give you the best tailored treatment for your needs. Okay, so going back to it. So, like I said before, there's some believe that there's greater public awareness, and that's increased teacher and parent referrals. And so really we're seeing more diagnoses when the rates actually haven't changed. It's always been out there to varying degrees. We're also more sensitized to spectrums of disorders, whether it be the bipolar spectrum or the autism spectrum. Now, some attribute the rise to changes in diagnostic criteria that capture more people potentially. Still, others suggest environmental factors, like I said, prenatally or postnatally, have contributed to this upsurge. This question raises further controversy regarding the treatment of young individuals, right? So many psychotropic drugs used for treating psychiatric disorders have been tested in adults, but few have been tested for safety or efficacy with children or adolescents. The most well-established psychotropics prescribed for children and adolescents are the psychostimulant drugs for treating ADHD, or attention deficit hyperactivity disorder. And the clinical data on these drugs' effectiveness is pretty robust. However, we know far less about the safety and efficacy in young populations of the drugs typically prescribed for treating anxiety, depression, or other psychiatric disorders. The young brain continues to mature until well after age 20, and so some scientists are concerned that drugs that alter neuronal activity in the developing brain could have significant consequences. Clinical trials in minors are needed to test the safety and effectiveness of these drugs, raising ethical concerns about consent, participation, and compensation. Now, elderly populations are often excluded from psychotropic drug safety and efficacy trials. Currently, little high quality evidence is available to guide prescribing for older adults, and clinical trials often exclude people with multiple comorbidities, aka other diseases or conditions, et cetera, which are typical for elderly populations. This is a serious issue because the elderly consume a disproportionate number of the prescribed medications out there. And the term polypharmacy refers to the use of multiple drugs, which is very common in elderly populations in the US. Demographic projections suggest that by 2030, individuals aged 65 or older will constitute approximately 20% of the US population, potentially accounting for 40% of prescribed medication consumption. So this table on this slide illustrates why standard clinical trials poorly capture the reality of elderly populations. Drug metabolism often slows considerably for older populations. So less of a drug can produce the same effect, or all too often, too much of a drug can result in a variety of side effects. One of the greatest risk factors for elderly populations is falling and breaking bones, which can happen if the elderly person gets dizzy from too much of a drug. So psychotropic medications can reduce bone density, thus worsening the consequences of falls. And despite growing awareness, geriatric pharmacotherapy presents complex medical and ethical challenges. Drug metabolism often slows considerably for elderly populations, so less of a drug can produce the same effect, or all too often, too much of a drug can result in a variety of side effects. One of the greatest risk factors for elderly populations, is that falling issue. So we have to be taking this super seriously. And so, when we think about this, we're really only providing an introduction to some important areas in the field of psychopharmacology. But this is something to take seriously, and for us to understand that at the individual level, factors such as age, biology, genetics, even our racial and ethnic background, because there are so many genetic variables that are passed down from person to person within different ethnic groups, can affect the way that we metabolize based on the environments that our ancestors were historically exposed to, and the foods that we historically ate, and the things that we had to respond to. So being really sensitive to the fact that this is not one size fits all is so key. Now, a few final points before we call it a day. Looking at how commonly recreationally used drugs affect neurotransmitters. Let's start with alcohol. Well, alcohol passes directly from the digestive tract into the blood vessels. And in minutes, the blood transports the alcohol to all parts of the body, including the brain. Alcohol affects the brain's neurons in several ways. It alters their membranes as well as their ion channels, enzymes, and receptors. Alcohol also binds directly to the receptors for acetylcholine, serotonin, GABA, and NMDA receptors for glutamate. Now, GABA's effect is to reduce neural activity by allowing chloride ions to enter the postsynaptic neuron. These ions have a negative electrical charge, which helps them make the neurons less excitable. The physiological effects are amplified when alcohol binds the GABA receptor, probably because it enables the ion channel to stay open longer and thus let more Cl negative ions into the cell. The neuron's activity would thus be further diminished, thus explaining the sedative effects of alcohol. This effect is accentuated because alcohol also reduces glutamate's excitatory effects on NMDA receptors. However, chronic consumption of alcohol gradually makes NMDA receptors hypersensitive to glutamate while desensitizing the GABA receptors. It is this sort of adaptation that would cause the state of excitation characteristic of alcohol withdrawal. Alcohol also helps to increase the release of dopamine by a process that's still pretty poorly understood, but that appears to involve curtailing the activity of the enzyme that breaks down dopamine. Now, with caffeine, the stimulant effects of coffee or an energy drink largely come from the way it acts on the adenosine receptors in the neural membrane. Adenosine is a neuromodulator that has specific receptors. When adenosine binds to its receptors, neural activity slows down and you feel sleepy. Adenosine thus facilitates sleep and dilates blood vessels, probably to ensure good oxygenation during sleep. Caffeine acts as an adenosine receptor agonist. This means that caffeine binds to these same receptors, leaving few receptors available for adenosine and its natural braking effect. Therefore, neural activity speeds up. The activation of numerous neural circuits by caffeine also causes the pituitary gland to secrete hormones that cause the adrenal gland to produce more adrenaline. Adrenaline is the fight or flight or flee hormone, so it increases your attention level and gives your entire system an extra burst of energy. This is exactly the effect that coffee drinkers are looking for. And in general, you get some stimulating effect from every cup of coffee. And any tolerance you build up is minimal. On the other hand, caffeine can create a physical dependency. The symptoms of withdrawal from caffeine begin within 1 or 2 days after you stop consuming it. And they consist mainly of headaches, nausea, sleeplessness, or sleepiness, I should say, and affect about 1 out of every 2 individuals, so 50%. And lastly, I should say, like most drugs, caffeine increases the production of dopamine in the brain's pleasure circuits, thus helping to maintain the dependency on this drug, which is consumed daily by about 90% of all adults in the US. Cannabis causes the sensations of slight euphoria, relaxation, and amplified auditory and visual perceptions. And these are produced due almost entirely to its effect on the cannabinoid receptors in the brain. Yes, we have built-in receptors that work for what we call cannabis. And these receptors are present almost everywhere in the brain and are an endogenous molecule that binds to them naturally. And so the point here is that no, we don't produce cannabis naturally, but we do produce a molecule called anandamide. And anandamide is an endogenous molecule that is probably, it basically parallels opiates, which bind directly to the receptors for endorphins, the body's natural morphines. And anandamide is involved in regulating mood, memory, appetite, pain, cognition, and emotions. And so when cannabis is introduced into the body, its active ingredient, the delta-9 THC, can therefore interfere with all of these functions. And THC begins a process by binding to the CB1 receptors for anandamide. And these receptors then modify the activity of several intracellular enzymes, including cAMP, whose activity they reduce. And less cAMP means less protein kinase A, and the reduced activity of this enzyme affects the potassium and calcium channels, so as to reduce the amount of neurotransmitters released. And so the general excitability of the brain's neural networks is thus reduced as well. However, in the reward circuit, just as is the case in other drugs, more dopamine is released. As with opiates, this paradoxical increase is explained by the fact that dopaminergic neurons in this circuit do not have CB1 receptors, but are normally inhibited by GABA neurons that do have them. Now, cannabis removes this inhibition by the GABA neurons and hence activates the dopamine neurons. In chronic consumers of cannabis, the loss of CB1 receptors in the brain's arteries reduces the blood flow and hence of glucose and oxygen to the brain. And the main results are attention deficits, memory loss, and impaired learning ability. Now, finally, we have opiates. Now, the human body naturally produces its own opiate-like substances and uses them as neurotransmitters. These substances include endorphins, diorphins, and calphins, and often are collectively known as endogenous opioids. Endogenous opioids are produced within the body and modulate our reactions to painful stimuli. They also regulate vital functions such as hunger and thirst and are involved in mood control, immune response, and other processes. The reason that opiates such as heroin and morphine affect us so powerfully is that these exogenous substances originating from outside the body bind to the same receptors as our endogenous opioids. There are three kinds of receptors widely distributed throughout the brain: mu, delta, and kappa receptors. These receptors, through second messengers, influence the likelihood that the ion channels will open, which in certain cases reduces the excitability of neurons. This reduced excitability is likely the source of the euphoric effects of opiates and appears to be mediated by the mu and delta receptors. These euphoric effects also appear to involve another mechanism in which the GABA inhibitory interneurons of the ventral tegmental area come into play. By attaching to their mu receptors, exogenous opioids reduce the amount of GABA released. Now, normally, GABA reduces the amount of dopamine released in the nucleus accumbens. And by inhibiting this inhibitor, the opiates ultimately increase the amount of dopamine produced and the amount of pleasure felt. Chronic consumption of opiates inhibits the production of C-AMP, but this inhibition is offset in the long run by other C-AMP production mechanisms. When no opiates are available, this increased C-AMP production capacity comes to the fore and results in neural hyperactivity and the sensation of craving the drug. Okay, well, I threw a lot of information at you, so that does it for this week's lecture. As always, turn to the discussion question and any supplemental videos that are posted, and I look forward to reading what you write for this week. Take good care, all. Have a great one.